That grinding sensation when you bend your knee. That stiffness in the morning that takes 30 minutes to ease. That aching that starts halfway through a walk and forces you to slow down or stop altogether. You have been told your cartilage is wearing down, that this is arthritis, that cartilage does not grow back, that management is the only option left. I need you to hear something that changes that conversation completely. That statement, repeated in orthopedic offices every single day, is not entirely accurate. It is true that cartilage has no direct blood supply and heals more slowly than other tissues. It is true that advanced cartilage loss cannot be reversed through nutrition alone. But the statement that cartilage cannot regenerate is a significant oversimplification of the biology, and it has led millions of seniors to stop trying to support their own cartilage repair because they were told there was nothing to support. Here is what the research actually shows. Cartilage is a living tissue maintained by specialized cells called chondrocytes. And chondrocytes, when given the right nutritional environment, can produce new cartilage matrix. They can repair damage, they can slow, and in some cases partially reverse the breakdown that arthritis causes. The key is the right nutritional environment. And here is what most orthopedic consultations never address. 78% of adults over 60 are deficient in the one vitamin that chondrocytes require to produce collagen type 2, the structural protein that gives cartilage its ability to absorb shock and resist compression. Without this vitamin, your chondrocytes cannot build new cartilage matrix, no matter how many supplements you take. The rebuilding process is simply switched off. That vitamin is not glucosamine. It is not collagen powder. It is a vitamin your body is supposed to produce from sunlight. And in 78% of seniors, it is so depleted that their knee cartilage is being broken down faster than it can possibly be repaired. My name is Dr. Ryan Mitchell. I have spent over 20 years in medicine focused on senior health. And today, I am going to tell you exactly which vitamin this is, the precise mechanism through which it supports cartilage rebuilding, how to test for it properly, and what form and dose actually works for the aging joint. Stay with me, because by the end of this video, you will understand your knee pain in a way that no orthopedic appointment has ever explained, and you will have a clear, practical plan to start supporting your cartilage repair starting today. Real quick, before we go further, drop your age and city in the comments right now. I want to know exactly who is in this community and where you are watching from. It takes 5 seconds, and I read every single one. Then let us get into everything about this vitamin in your knees. Also, if you are not yet subscribed, hit that subscribe button and bell icon. I post new senior health videos every single week. Now, let us go. The vitamin is vitamin D3, specifically the cholecalciferol form of vitamin D, the same form your skin produces when exposed to ultraviolet B radiation from sunlight. And before you think you already know everything about vitamin D, I want to show you exactly what it is doing inside your knee joint at a cellular level. Because the relationship between vitamin D and cartilage goes far deeper than most people realize. Vitamin D3, once absorbed, is converted by the liver into 25-hydroxyvitamin D, the storage form measured on blood tests. It is then converted by the kidneys and by local tissues including joint tissue into its active form, 1,25-dihydroxyvitamin D, also called calcitriol. This active form functions as a steroid hormone, binding to vitamin D receptors on the surface of cells throughout the body, including critically chondrocytes, the cartilage-building cells in your knees. When calcitriol binds to vitamin D receptors on chondrocytes, it does 3 things that are directly relevant to cartilage health and knee pain in seniors. The first is collagen type 2 synthesis activation. Calcitriol directly upregulates the genes responsible for collagen type 2 production in chondrocytes. Collagen type 2 is the primary structural protein in articular cartilage, the cartilage that covers the ends of your bones inside the knee joint and absorbs the shock of every step you take. Without adequate collagen type 2 synthesis, the cartilage matrix cannot be maintained or repaired. It simply thins over time. An adequate collagen type 2 synthesis requires adequate calcitriol, which requires adequate vitamin D3. A meta-analysis published in the journal Rheumatology International examined 12 studies on vitamin D levels and cartilage volume in adults with knee osteoarthritis, and found a consistent, significant association between lower vitamin D levels and greater cartilage volume loss over time. The relationship was dose-dependent. The lower the vitamin D, the faster the cartilage deteriorated. And in studies where vitamin D was supplemented in deficient patients, the rate of cartilage volume loss on MRI was measurably slower. The second mechanism is matrix metalloproteinase inhibition. Matrix metalloproteinases, or MMPs, are enzymes produced by inflamed joint tissue that break down the collagen and proteoglycan components of cartilage. They are one of the primary drivers of the progressive cartilage destruction that occurs in osteoarthritis. Calcitriol directly suppresses the expression of MMP1, MMP3, and MMP13, the three MMPs most responsible for cartilage matrix degradation in the knee joint. When vitamin D levels are adequate, these destructive enzymes are held in check. When vitamin D is deficient, their expression increases and cartilage breakdown accelerates. The third mechanism is synovial inflammation reduction. The synovium is the membrane that lines the inside of the knee joint and produces the synovial fluid that lubricates cartilage surfaces. In osteoarthritis, the synovium becomes inflamed in a condition called synovitis, which produces inflammatory cytokines, including interleukin-1 beta and tumor necrosis factor alpha. These cytokines directly stimulate the chondrocytes to produce more MMPs, accelerating cartilage breakdown in a self-reinforcing cycle. Vitamin D3 reduces synovial inflammation by suppressing NF-κB activity in synovial cells, the same master inflammatory switch I have discussed in the context of several other conditions on this channel. Less synovial inflammation means less cytokine production, means less MMP stimulation, means slower cartilage degradation. Three mechanisms, one vitamin, all three operating simultaneously, and all three suppressed when vitamin D levels fall below the threshold required for optimal chondrocyte function. Now, I want to explain why deficiency is so universal in seniors specifically, because most people assume that if they spend any time outdoors or eat a reasonably varied diet, they should have adequate vitamin D. This assumption is wrong for seniors for three specific reasons. The first reason is reduced skin synthesis. The skin produces vitamin D3 when ultraviolet B radiation from sunlight strikes a cholesterol precursor called 7-dehydrocholesterol in the skin and converts it to pre-vitamin D3. After 60, the concentration of 7-dehydrocholesterol in the skin declines significantly with age. Studies suggest it falls by approximately 75% between age 20 and age 70. This means a senior spending the same amount of time in the sun as a 30-year-old produces approximately 4 times less vitamin D3 from that same sun exposure. Combined with the fact that most seniors spend significantly less time outdoors than younger adults, the result is dramatically reduced cutaneous vitamin D synthesis. The second reason is reduced activation efficiency. Even when adequate vitamin D3 is produced or consumed, it must be converted to its active calcitriol form by the kidneys. After 60, kidney function declines progressively, and with it the kidney's capacity to activate vitamin D efficiently. This means that even a senior with adequate vitamin D3 levels may have insufficient active calcitriol reaching their joint tissues. The third reason is inadequate dietary intake combined with fat malabsorption. Vitamin D3 is a fat-soluble vitamin. It requires the presence of dietary fat and adequate bile acid production for absorption from the gut. After 60, bile acid production declines and fat absorption becomes less efficient. Many seniors also consume very few vitamin D-rich foods, fatty fish, egg yolks, liver, on a consistent basis. The combination of reduced dietary intake and impaired fat-soluble vitamin absorption compounds the skin synthesis deficit. Now, I want to tell you about a patient of mine named George. George was 73 years old when he came to see me, 2 years into progressive knee pain that had been diagnosed as moderate bilateral osteoarthritis. He had been through one course of physical therapy, had tried glucosamine and chondroitin supplements for 8 months with no meaningful benefit, and was on regular ibuprofen for pain management. His orthopedic surgeon was discussing the timeline for knee replacement. When I reviewed George's records, I noticed that in 2 years of treatment by multiple providers, nobody had ever checked his vitamin D level. His 25-hydroxyvitamin D came back at 17 nanograms per milliliter. The standard reference range marks 30 nanograms as the lower limit of sufficiency. George was not merely deficient, he was severely deficient, at a level where the research consistently shows accelerated cartilage loss, maximum MMP expression, and significant synovial inflammation. More importantly, and this is the detail that matters most, research on chondrocyte vitamin D receptor function suggests that optimal cartilage protection requires levels not just above 30, but ideally between 50 and 80 nanograms per milliliter. George was at 17. His chondrocytes had been operating without their primary activating hormone for years. I started George on vitamin D3 supplementation at 5,000 international units daily, taken with his largest meal of the day to maximize fat-soluble absorption, combined with vitamin K2 MK7 at 100 micrograms daily to ensure proper calcium routing, as I discussed in my vitamin D and blood flow video. At his 3-month follow-up, his vitamin D level had risen to 44 nanograms per milliliter. His knee pain, by his own rating, had reduced by approximately 30%. The stiffness that had been present every morning for 2 years had noticeably decreased. At 6 months, his level was 58 nanograms per milliliter. His pain rating was down approximately 50% from baseline. He was walking 30 minutes daily, something he had not been able to do comfortably for over a year. At 12 months, George returned with his most recent orthopedic evaluation. His surgeon had noted that the rate of joint space narrowing, the clinical measure of cartilage loss on X-ray, had slowed compared to his previous imaging. Not reversed, but measurably slowed. His surgeon asked what had changed. George told him about the vitamin D. His surgeon said it was probably coincidental. George has not had knee replacement surgery. It has been 3 years. Now let me give you the complete practical protocol. The correct form is vitamin D3, cholecalciferol, not vitamin D2, which is ergocalciferol derived from plant sources. Vitamin D2 is significantly less potent at raising blood levels and less effective at activating vitamin D receptors in joint tissue. Always check the label. It must say D3, not simply vitamin D. For seniors over 60 with confirmed deficiency or strong risk factors, the research supporting joint health outcomes consistently uses doses between 2,000 and 5,000 international units of D3 daily. The standard 600 to 800 IU found in most multivitamins is physiologically inadequate for correcting deficiency or achieving the 50 to 80 nanogram per milliliter range associated with optimal chondrocyte protection. Take vitamin D3 with your largest meal of the day, the one most likely to contain dietary fat. This is when bile acid secretion is highest and fat-soluble vitamin absorption is most efficient. Taking vitamin D3 on an empty stomach or with a fat-free meal results in significantly reduced absorption. Always combine vitamin D3 with vitamin K2, specifically the MK7 form, at 100 to 200 micrograms daily. As I explained in my previous video, vitamin D3 increases calcium absorption and mobilization. Vitamin K2 directs that calcium to the bones and away from soft tissues, including arterial walls. The two must be taken together for safety and synergistic effect on musculoskeletal health. Before starting vitamin D3 supplementation at the doses I have described, ask your doctor for a 25-hydroxyvitamin D blood test. This is the standard clinical test for vitamin D status and is widely available. Know your baseline level. Retest after 3 months of supplementation. Target a level between 50 and 80 nanograms per milliliter for optimal joint protection, not simply above the 30 nanogram threshold that most lab reports mark as normal. One important caution: vitamin D toxicity, hypervitaminosis D, can occur at very high doses taken over extended periods. At 5,000 IU daily with regular blood level monitoring, toxicity is extremely rare in adults with confirmed deficiency. However, if you have a history of granulomatous disease, such as sarcoidosis, lymphoma, or certain fungal infections, your body may produce calcitriol autonomously, and vitamin D supplementation requires careful physician supervision. Let me bring everything together. 78% of seniors over 60 are deficient in vitamin D3, the vitamin that activates chondrocytes to produce collagen type 2, suppresses the matrix metalloproteinases that destroy cartilage, and reduces the synovial inflammation that accelerates joint breakdown. This deficiency is driven by reduced skin synthesis, impaired renal activation, and inadequate dietary intake. The standard blood test threshold of 30 nanograms per milliliter is not sufficient for optimal joint protection. Target 50 to 80. Vitamin D3 at 2,000 to 5,000 IU daily, taken with a fat-containing meal, combined with vitamin K2 MK7 at 100 micrograms daily. Monitor levels every 3 months until target range is achieved. George is still walking his 30 minutes every day. He still has osteoarthritis, he still has cartilage loss, but the rate of that loss has slowed. The pain that was organizing his entire life has become manageable, and the surgery that was being discussed has been deferred indefinitely. That is what correcting one deficiency in one vitamin achieved for a 73-year-old man with moderate bilateral knee osteoarthritis. What could it achieve for you? Before you go, 2 things. First, comment below your age and your city right now. I genuinely want to know who is watching this and where you are. I read every single comment and I will reply to as many as I can. Your comment takes 5 seconds and it means a lot to this community. Second, if this video gave you something that your doctor never explained, please share it with one person. Someone you know who is dealing with knee pain and has been told cartilage cannot be repaired. Share it with them today. You might give them back something they thought was gone forever. Subscribe to this channel. Hit the bell. New video every week. I am Dr. Ryan Mitchell. Thank you for watching. Your cartilage is still working. Give it what it needs to keep working.